So I'm joined today, as always, by my fellow GoggleDocs, Patrick and Amar. Good to see you both.
Hey, Amrit. Hey, everyone. Hey, Patrick.
It's been a busy few weeks, I think, in terms of certain medications, the incretin therapies in particular. And so I think today we're going to focus mainly on that area. And maybe we can just wind the clock back a little bit, because when we first started using incretins in the management of type 2 diabetes, it was quite a shift change. It was the first non-insulin injectable that I started discussing with patients. So I still remember those early conversations that I was having for once daily. For me, it was once daily. For me, it was liraglutide, which was the first GLP-1 that I was using.
So this is where I come in with Father Time. So it was back in 2005. You were probably both still at school. But yeah, that's when the first incretin GLP-1 agonist was launched. That was Byetta. So which
2005. That long ago.
2005. Yeah.
Wow.
So that was a twice daily injection, as you say. We moved on to a once daily injection. I can remember having those conversations, and patients being super excited about that. There've been other products which have come along. I suppose a key date was probably, if we fast forward right through to 2017, when we suddenly got the first data to show that these drugs, as well as lowering glucose and lowering weight in patients at high risk of cardiovascular disease, it actually reduced mortality in that case. So and then we've got a whole new wave of once weekly GLP-1s and beyond, which perhaps we'll discuss later on, which certainly are my go-to products now, because they have greater glucose lowering effects, they have greater weight reduction effects generally, and are more convenient, quite honestly, for patients. And then if we want to go right up to speed, of course, there's oral therapies now, certainly one, which is available. And these products are not just, or some of these products, I should say, are not just licensed in the treatment of type 2 diabetes, but now, because of their impact on weight, particularly the newer generation ones, they're also licensed, or some of them are licensed for weight loss in people who are obese.
I think that's interesting, actually. From what you said, Amrit, the first one you prescribed was liraglutide once a day. And that shows, because you've been practicing a little longer than me, and I certainly was prescribing exenatide BD, so Byetta, and Bydureon, of course, the once weekly exenatide. And I remember that early, because I remember having to do a presentation on it, and the trusty Gila Monster picture that I always use and still use. I still got that. I still use that. I remember putting that in Lizard Spit, Exendin 4, wasn't it? So I remember that, and remember, in the 1990s I started exploring, 92 wasn't it, and developed this molecule. So I remember prescribing that a few times, and up until recently, up until fairly recently, it was I think it was probably 2013, 14, I think, when it's the liraglutide used to start using a bit more of that, and then the subsequent generations of gelaglutide and semaglutide came in. So again, probably second shows that secondary care was where most of the GLP-1s were being used at that point, and then primary care came forth more and more. So even now, still not as much. Okay, I can see you looking a bit cynical there, Patrick.
No, not in my neck of the woods. I think it's been mainly used in primary care, but because of course that's where most people with type 2 diabetes, and I suppose one of the things, just in terms of the history, they were originally seen, and perhaps it's still, as far as NICE are concerned, really as an alternative to insulin. But of course, the clinical data suggests that actually possibly the earlier in the disease, the better, when you've got more pancreatic capacity and reserve, the better you get the response. And I think, and I certainly what we're seeing with a lot of the data coming out, it does point to earlier use. And I can remember the early studies, certainly of liraglutide, they looked at using it before insulin, and that was quite a game changer as far as I was concerned, because it was, as you say, it was as an alternative to insulin rather than before and with potentially insulin. So
I think it still has a bit of that legacy, doesn't it? It's an injectable, therefore it should be reserved for later down the line. And I think the most recent NICE guidelines have reinforced that idea, haven't they? But I think there are a few milestones for me. One was when we first started to see once weekly GLP-1s. I think that was a bit of a game changer moment, particularly for people who were prescribing it for. Then the next milestone was the cardiovascular outcome data, where we saw in the ADA EASD consensus statement really being positioned, pretty much straight after metformin. Was it straight after metformin? I'm trying to think of the incarnation of the ADA statement at that stage.
It was cardiovascular benefit at that point, wasn't it? And it was both, because at that point we'd had EMPA-reg outcomes with empagliflozin, and we'd had leader with liraglutide, which had both come quite soon, and Canvas came on just not so far. So we had more evidence in the SGLT2 department, but liraglutide was the one that had that cardiovascular benefit that really prompted a lot of those changes. Yes.
Which then I think led to some of that being bled into local guidelines as well. The cardiovascular focused management of type 2 diabetes, moving away from that glucose-centric management, so SGLT2 inhibitors and GLP-1s really. So that was a landmark kind of moment. And then the oral version of the GLP-1, I think that's probably the third milestone for me, where people who were slightly reluctant to have an injection could have the option of having an oral tablet. So for me, those have been the major ones. But I think the last couple of years, it's gone even further, hasn't it? I mean, what's that look like?
Yeah, so you've seen that transition, I guess. I mean, GLP-1s were always, I guess, you said instead of insulin, but actually there were also the stringent rules around weight, wasn't there, and BMI cutoffs and benefits in terms of reduction in weight and HbA1c as well concurrently. So that's always been one of the key things when you're looking at GLP-1s was about the weight aspect for a lot of our patients, and so that's just got extrapolated now. So now that we looked at more weight loss really with these medications and looking at almost from a pure weight centric management rather than looking at the glycemic lowering, and that's where we got a few more trials looking at that. And I think it was really semaglutide that pushed that the STEP program, and those kind of the burst of all the STEP 1 to 2 or 5, and when they came out, that was, I remember being at ADA when we got a fair few of those, and I remember thinking, wow, this is some impressive stuff where we've moved. I guess it wasn't, it was different, but we'd had some precedent with SGLT2s in the movement to cardiology and nephrology. And so when it moved to obesity, it made sense, and it was very interesting, and it was really clever that it was being done. And it just meant that there was a whole new area now to look into. And that was really the first steps in that, with the highest strength GLP-1. And looking at it purely from obesity spectrum, especially if you look back and see what medications were there. I remember this because, again, in secondary care, some of the endocrinologists do look after a lot of the weight management. And there wasn't really an obesity specialist at the time. There were very few, and the training wasn't quite clear. So when I was going through training, we had obesity as part of that, but it wasn't as well fleshed out as some of the as endocrinology and diabetes was. And so when you got that, and you look at the prior medications in the UK, it was only really Orlistat and Senecal, which we had, which was a possibility for pure weight lowering, and the side effect profiles. I think Amit's smirking at that, but. The flatulence and GI side effects and incontinence. Yeah.
So I was just going to say, the reason I'm smirking, I was in a meeting, one of our primary care network meetings just the other day, and there was a GP asking, "Is anyone still prescribing all this that?" And it just made me chuckle a little bit, because it's interesting. We don't have a weight loss pathway locally, so perhaps I'm jumping ahead a little bit here, but we're still, although we've now got certain molecules that are showing very impressive weight loss, access to it is a big issue. But we'll come to that. Sorry, back to what you were saying, Alan.
Something that, again, you mentioned an interesting point about awareness as well as and access, because again, a lot of people weren't really using that. So that was the only real option. Of course, weight loss programs, low calorie diet programs, and low carbohydrate programs. There were a few things that we could use, but this really put it as this is a medication that we had fairly good confidence with. and actually had safety as well, a lot of the cardiovascular safety, because some of the medications that have been used perhaps weren't had concerns around that with weight, appetite suppression, and etc. So these GLP-1s were the ones that we'd used. We'd use it in diabetes, so we knew in type 2 diabetes, we knew about it, we knew how it worked, we were fairly comfortable with it, and now it's a different, I guess, a different area we could use it in. Meant the medication we were comfortable with, just the area we were using it in was a bit more to think about. And so the STEP programs did that, but then we've seen over the last kind of 2 years or so, the dual incretins have now taken charge, really. We've got GLP-1s and GIPs, so tirzepatide. We've got GLP-1s and glucagon agonists as well, so survodutide, as amongst others, of course. And then we've also got now companies looking at once monthly dual agonists as well. We've got cagrilintide and semaglutide amylin analogs and the GLP-1s. We've got people looking at oxyntomodulin, neuropeptide YY, and we've also got now triple agonists as well coming through with GLP, GIP, and glucagon later on in the 2020s. So a lot has been pushed, and this incretin molecule has now been expanded more, and I think that's kind of interesting to see how it went for so long with just a single molecule. Now we've got double and triple and any combinations of that, and it's really changing, I guess, in setting of type 2 diabetes, how we look at it, looking at more so on weight and the reversibility of that, but now we're looking at it from an obesity perspective as well, and the comorbidities associated with obesity, and we've now switched the focus a little bit to obesity now as well as a result of these molecules, because we've actually had something that we can utilize now. So it's really fascinating how that journey has progressed over the years, but it's really been the last couple of years. I mean, obviously the molecules have been in development for a while, but the last couple of years with the trial data coming through and such strong data and uniformly strong data on all these dual molecules have all shown superior weight loss to traditional GLP diabetes GLP-1, if that makes sense.
Where's that intersection between management of type 2 diabetes and weight loss at the moment, Patrick? What are your thoughts about that?
Well, I suppose in clinical practice, we're still, I think, really access outside of private weight loss clinics is really quite minimal. So in clinical practice, I think obviously we've got supply issues, which are certainly blighting management of type 2 diabetes, perhaps because of the popularity in private weight loss clinics and the global popularity in post-pandemic, in both increasing glucose levels and increase in waistlines. So fueling all of that. But so I think in clinical practice we're still as it often is the case, we're behind the clinical trial evidence. So we're still using these agents as treatments primarily for glucose lowering, but with the definite added benefit, and I think that's clearly focused for a lot of people in terms of weight, and indeed NICE will tell us to focus on people with comorbidities related to their weight. So which is numerous and very common in general practice, from chronic back pain, osteoarthritis, obstructive sleep apnea, as well as metabolic liver disease, etc. So I think that's where we are. But clearly, in terms of the clinical trials, there is a left shift. We are moving now more into that preventative piece, which goes back to what I said. Instead of seeing these things as treatments for the end of a disease, really we should be looking at preventing some of these complications from ever starting. Why leave people with X number of years of dysglycemia and dyslipidemia related to the type 2 diabetes, when potentially you could reverse some of those things through medication. I mean, there's some philosophical issues there, and obviously there's finance issues there, and affordability issues. But we now have the technology of this bariatric medicine, I suppose, is where we're now in the field of, and I think we do know, that this has a huge impact as weight gain in terms of healthcare costs. I think there was a report earlier on this year which showed people with a BMI of 40 would double the costs of people with a normal BMI in terms of NHS costs, and there were incremental increases through those different bands of BMI, 30, 35, 35, 40. So there is, we're almost in this situation. Can we afford to treat obesity medically in this sort of way? Who should we prioritize? Can we afford just to ignore it? You know, and I think you know, from a global perspective, it's probably very challenging because these drugs are often not covered by insurance plans, etc. So access is really on the ability to pay, which obviously, you know, exacerbates health inequity. We're fortunate in the UK that we have a health system that at least stops those costs, but it's, you know, this, we're talking about a very prevalent condition. There is huge demand for these treatments, often with people with actually quite lower BMIs, where perhaps the medical necessity isn't quite great there. And as I said, blighting the whole thing is the supply issue. So it feels like for us to make a left shift, we need greater quantity of these drugs, and they need to be affordable to health systems and individuals to be able to utilize these. And I think that pipeline which Amar points to is really important because, you know, you know, I can say this looking back in my career, there's lots of products now which are generic. Statins were branded when I started, all of them were, you know, so and now they're all generic and now affordable and accessible, you know, assuming people want them. And I think we will get to that stage with some of the molecules which have been mentioned, which will be widely available, but that's going to take a number of years, and how we navigate that, I think, is a real challenge for health systems, for patients, for doctors trying to treat those patients, or nurses, pharmacists, for that matter. So you know, I think, but the data is telling us where we're going, and I see that clear as day. It's really how we can follow that data without creating sort of research inertia or clinical practice inertia, you know, because I think there are social issues about, you know, should we treat, is obesity even a disease? Is it a lifestyle choice? Those sorts of things, you know, impact on policy decisions, I think, still. So it's, but for the UK, you know, we're the heaviest in Europe on average. So this is a real challenge to our health systems and the sustainability of them. You know, I feel it strongly for myself because Northeast North Cumbria is where I work, and that is again the heaviest in the UK. Sorry, in England. I think there are areas in Scotland which are more challenged, and we can see that putting real strain on the health systems. You know, now, not in future.
Of course, you reminded me there, Patrick, because one of the things I didn't mention is the small peptide oral GLP-1, which are coming through as well. There are two at the moment. I think that's kind of fairly advanced in the phase trials. I think phase 2 and now into phase 3. For Gripon and Denogripron, but Gripron, there we go, Gripon. Funny way to
Sounds
say
like
it.
a transformer.
I was about to say, I just need to add a prime to the end, don't they? But yeah, so those might potentially meant to be cheaper to produce and make, so they might support that. But again, we're also having GLP-1s that are coming off patent, and so again, where do we see those as well? And also interesting, where do they get used? Where do we see obesity medicine occurring? I mean, if we're saying this is more a public health concern or it's kind of more of a general thing rather than specialist, doesn't that put you two really at the forefront of this? At the moment, that's not possible because of, I guess, time constraints and what's it called again? Not just time constraints, workforce constraints, I guess. But also it's a whole new kind of area that involves, you've got to set up, you know, not just the medication side, it's actually all the stuff before it, isn't it? It's the diet, lifestyle, exercise. It's that, and really pushing that. We shouldn't forget about that. And these medications, because we don't want to we're jumping 3-4 steps ahead, and also bypassing surgery for an extent by looking at this, because it's a relatively simpler thing for us. You could argue whether that is true or not. But yeah, and that means for you two, and you lot, that's involving a separate kind of area and tiering system. I mean, the tiers are not tiers or general management. You manage cardiovascular disease, now you manage type 2 diabetes, and now you're going to add obesity to that.
I wonder whether this will go down the way of, you know, the National Diabetes Prevention Program, low calorie diet pathways, which are in the community, but not generally within the GP surgery. But you make a really valid point, because there'll be plenty of people who are, you know, firm believers and, you know, actually it's a foundation of type 2 diabetes management, isn't it? Lifestyle. And are we at risk of becoming too excited by the efficacy of these really impressive molecules, but in doing so and engaging with that, leap?
You might have cut out there, but while he's fixing that, and I still can't hear him.
Well, I'll come in on that because I think, first of all, I think it's a bit different from a very low calorie diet. So first of all, I agree with everything you said. I think we are at risk of jumping too ahead. I think clearly the basis of, as you say, of good health, never mind good management of type 2 diabetes, is good nutrition. There's a preventative piece because I think that treating obesity and preventing obesity are two different threads, really. And I suppose, I'm guilty of being a doctor here rather than a public health doctor. So I'm looking at treating the people who have a disease. But clearly we need to prevent because that's, again, talking about sustainability, that's really important and it really challenging because of the nature of our society and who tends to become obese, etc. There are lots of other associations, so it's really tricky. So I'm trying to make it easier for myself by just focusing on those people who already have developed the condition. And clearly nutrition is really important. Affordable nutrition is also important. So this is not just about doctors; it's about society and how we incentivize things. But it's also different from those diabetes prevention programs or low calorie diets in a sense that there are quite a lot of harms and checks that need to be done. We know of cases where people have given the incorrect details so they can access these drugs, but they may have an eating disorder. These drugs can also cause problems when it comes to anesthetics because of the slowing of gastric emptying. So and that's there. Obviously, there's the general side effects that people get. They're even looking at some countries. They're even looking at some links between mental health problems, depression with some of these agents. So there are still. These drugs are not without their adverse effects, as well as the adverse effects on the financial pocket, whoever's paying for it. But to implement it, I think it is a little bit more challenging because of these other issues, but they're not insurmountable. And I think, and just on, because the NHS England are funding and resourcing pilots, certainly we've got some pilot sites, but you're right, Amrit. They are badged as GP, but they're not GP. These are above a standard GP level, and also we need to, there was a lot of noise about it and saying, there's this GP pilot of this new, Wegovy high dose semaglutide, but the actual number of places where this is a drug based on the NICE calculations, 4.2 million people in theory will be eligible to this product, based on the criteria that NICE says, and the GP pilot actually is probably about 1,000 to 1,500 people. So clearly this is a drop in the ocean, and we are in very early stages. And there's but the desire and interest. I don't know about you, Amrit. How many people have you had in your practice coming to you asking about can they have that injection for weight loss? Particularly if you're talking about Orlistat, they'll quickly dismiss that and say, no, I didn't want those tablets again. I gave me those before. We fell out over that. What about this injection?
Exactly. Well, interesting you say that because we shouldn't forget about the slightly older molecules. I think in this, and particularly in type 2 diabetes, I know we have a supply challenge at the moment, but that question was first asked to me by a patient of, could I have that injection that my neighbour's having? He's lost loads of weight with it. I'd love to be on the same thing. And he was talking about dulaglutide. Right? Yeah. So there are other options there for people perhaps with type 2 diabetes, but I think if we're really talking about the big guns in terms of people who have quite significant weight difficulties, then sure.
So what are we saying? Should the government be doing more on that side of things? We've done the sugar tax. We've seen that happen in Mexico and other places. And have you seen the other day, Colombia put in a processed food? They're changing how processed food is being consumed, and actually trying to stop that from happening as well. So these are kind of more population-based public health / governmental kind of changes which will have impact, and perhaps in terms of upfront money costs and things, maybe those are the kind of things that need to be done more so than these medications. I don't know. I'm just throwing it out there.
Oh, 100%, Amar. I think we live in an obesogenic environment where, I always say to my patients, we're inherently lazy human beings. Otherwise, we wouldn't have invented the wheel. I mean, so we but actually, cars. Again, when I was a kid, shopping was a trip up the high street, me carrying bags for my mother, going from one shop to the next shop. I used to hate it. And then now, and then walk, a mile back home. But now it's a trip to a supermarket. We have a little trolley. We can put our stuff in the trolley, wheel our trolley right back to the car, put the stuff back into our car, drive it home, and we've just got to take it out from the car to the fridge, and they're wonderfully exciting, calorific foods which are tasty, blah blah blah. But sadly, the ones which are cheapest, just going back to your point about, unfortunately, are often the unhealthiest. Frozen pizzas. Deep fried this, deep fried
Don't
that.
Not frozen pizzas. Don't not frozen pizzas. No, I'm joking. Yeah.
But for we're in the middle of a cost of living crisis. I think it affects people across a broad spectrum. But those people are really struggling at the bottom. They've to fill bellies. They haven't got much choice. So I think this is about government action, and it's about dissuading people, to make the right choices. We do it in other things. Seatbelts are a common practice in this country. We generally stop at red lights. There are laws in there to keep us safe, and for that matter, keep other people safe. And the same surely should apply to our health. But then there's almost like, then we're in the world of politics, which I always takes me to my dark place. But, because we've got libertarian views, which say everybody should have choice. We're adults. Surely we have choice. But then we've got a health system in the UK, at least, which is funded through taxes. So you think, well, that doesn't quite add up if we're spending increasing amounts of money. 10% of the NHS budget is on diabetes, and most of that's on type 2 diabetes. So, and its complications. So we're paying for it somewhere. So I strongly feel there should be a place where government actually do try to incentivize and encourage good behavior, health behavior, and make it more affordable, so the choices are easier. Because I think most people want to make the right choices.
Yeah, I think this is probably even more important now than ever before. We're seeing the rates of overweight and obesity kind of skyrocketing across the world, aren't we? But also, just coming back to the accessibility to these new medications, it's like with any technology, isn't it? There's always a risk that it will actually increase the divide between those. I mean, if you think about digital technology, for example, those who are digitally savvy versus those who are not, are we increasing that gap? And there's potentially what we've already actually seen, to be fair, with semaglutide, for example. Those who've been able to afford it privately in certain parts of the world have been able to use it to very good effect, leaving the rest of the world essentially with nationalized health services, for example, at a loss because there's no stock available. So we've already started to see that, and I think this is a really important. It is going to be a government and a politically driven sort of process, I think, how these newer medications are utilized and made accessible, whilst also balancing the lifestyle measures and all those critical public health messages as well. Talking about sorry, go on, Emma.
No, good. I think I was just going to add something about, I guess, the changes we're seeing, but no, don't worry about it. You carry on.
Okay, fair enough. No, I was just going to say, this current crisis that we have with stock, I think we can't have a conversation about this class of medications without talking about that. Patrick, I know you feel particularly strongly about this. Is there something, do you want to kickstart the conversation?
Well, I've already mentioned a little bit before, so I suppose what we've got is a bit of a perfect storm going on in terms of these products. So they were developed for the management of type 2 diabetes. As you say, it's a very recent shift in terms of the world of weight loss with these, third generation incretins and the twinketrins, if we call that, with tirzepatide. So these are new, but they've caught the eye of celebrities. Elon Musk's on it, and so they've got this huge visibility. Unfortunately, often the brands are the ones which are actually the type 2 diabetes brands, like Ozempic, which then directly impacts on people who actually are already showing complications related to their weight. So these are people who are medically, I would say, more worthy. I mean, it's always difficult. There's worthiness across, and I'm sure people could easily come back to me on that one. But they're showing they're accruing healthcare costs. So if you're looking at purely from a utilitarian view, these are ones that are starting to cost us. So the perfect storm is partly the data, then partly the pandemic, of which has increased poor control of diabetes and waistlines in the population, or at least in some. Which has increased demand for all diabetes products, but including these incretins. And then because of this sort of, and it is almost a viral explosion of demand for weight loss, skinny jab type products, that's has caught these companies out, so they're literally building extra factories because they can't. The specialized plastics involved in these products are being impacted. It's actually even worse than that for those of us who are trying to manage people living with both type 1 and type 2 diabetes, because some of the insulin products have now been hit with it because they use the same pen as Ozempic, for example, and so that's impacting a broader group of people and causing additional workload within healthcare systems, switching people from one insulin to another, which isn't always straightforward, because of the risks of insulin, if you get it wrong, are not great. So that's where we are right now. I mean, you would think that these companies, which by the way are hugely valuable because of this. I think Novo Nordisk is now the number one company in Europe, and I've noticed Lilly's price has sort of skyrocketed in this last year. So these are two companies which produce most of the eye-catching weight loss ones, both now and a pipeline in the future. So clearly the market sees this as a hugely valuable area, and we get these products, but of course. Yeah, so that's the supply issue. So we'll get more products, but of course the global demand is enormous, and there are a whole load of supply chains, as we know. Everything from, if you're trying to buy a car or a computer, it's not just pharmaceuticals where there's supply issue.
I think that part of the concern for a lot of people, a lot of specialists, I guess, is the population with type 2 diabetes. We don't want them to miss out on medications which are more than aesthetics, are therefore clinical relevance. I mean, we're not arguing against obesity as well, but again, with the private clinics in that way, there's the argument. A lot of clinicians who look after people with diabetes, type 2 diabetes, are very possessive of the fact that we need these for our patients, and there's the concern that if there is kind of push towards obesity, what happens to the people with type 2 diabetes as well? And the arguments, yes, okay, people with obesity do need this to go down the line to prevent the complications. But the people who already do have the family effects of obesity at the moment, which if you're saying type 2 diabetes is related in some cases, then that's what we're looking at, and it's about preservation of that and not forgetting about the OGs, the original people who use these medications, compared to the ones who will be needing it, the new kind of cohorts. I think that's a valid point, and again, it's down to a combination of, yes, maybe industry, but also clinicians and government and societies to kind of really highlight and really kind of focus and take charge of the situation, almost to kind of say this is what we're doing, and on the backdrop of all the things that you said, Patrick, as well, to kind of ensure that the people who need it the most, and there's equity of use as well of that, get it.
let's perhaps move on and just consider a little bit about the practicalities of, clinicians who are working in practice wanting to use these molecules. So in terms of availability, the messages that we're getting from, you mentioned Novo Nordisk and Lilly for their GLP-1 molecules, is that Q1, Q2, mid-year 2024, we should see the supply essentially going back to normal. Is that right?
I think, well, I don't know about as early as that. I think some of the products are going to become more available. That's my understanding, such as the tablets, actually, the Rybelsus, the oral semaglutide. I think that's likely to become more available sooner. But yeah, I think the official line is really there's interruption of supply right through really until probably May of next year, and then it may be beyond that. But the one thing I always sort of explain to people, if some of this is all to do with the private weight loss market, that has a very seasonal character. People generally start in February and March, and they generally stop sometime in the summer. So we are getting interrupted supply. So at the moment, most of my patients who are on these products are actually able to get hold of it if they're patient. And there's people who have been on it, we've had to switch off, who are saying, "Oh, can I go back on it? I hear it's back in stock." And then I'm thinking, well, that's fine, but then we've got the whole palaver in 2 or 3 months' time going backwards. So it's very frustrating for patients. And as you say, there are some patients, particularly with type 2 diabetes, who've got established cardiovascular disease, who we know actually it can extend their life potentially, and it can certainly help them avoid things like stroke or heart attacks. So and I think that's the bit which I think it's difficult as a clinician. If you've got patients, these are potentially life extending treatments, as you say, when there's other people where there isn't that evidence that it will have that degree of benefit, will maybe improve other aspects of their life, but not necessarily extend it. But yeah, I think that supplies are going to pick up, but exactly when is uncertain, because I think the demand is global, it's unpredictable, and even when these companies can't produce new factories, is that going to keep up with demand? I mean, we've got tirzepatide, the twinkotrin, I think, is now licensed in the UK. It's got nice approval for type 2 diabetes. It's got, as you say, it's licensed from the MHRA for type 2 diabetes, and now just recently for weight loss. So although that product, I think, is going to be launched this month, I don't know for sure, but I think it is from what I hear, then, is that going to be a game changer? I don't know. I mean, the data's fabulous. Both in type 2 diabetes and in obesity, with a similar side effect profile to what we see with the high dose GLP-1s, but is that molecule going to be hit with supply issues? It certainly appears to be blighted by that in the States, because there's only so much specialized plastics to make these pens. So I don't know, but yeah, we're going to have another one on the block very soon. And patients, I've already got patients asking me about it. So
yeah, so
it's aware about that.
So it's certainly not being released in the UK with the same pen as we saw for Trulicity. So that, as you say, is already something that's a little bit of an unknown. But just to recap, what is the top line difference that we're seeing in terms of data for tirzepatide? What's so special about it?
Tirzepatide is this sort of twinkotrin, so it works on GLP-1 and another incretin glucose. Yeah,
inotropic peptide.
Yeah, I know. I can never get my head around that one. They changed the name as well a while ago. But yeah. So it has, although it's one molecule, it affects 2 receptors, and the sort of top line data is, in a sense, because they've done a head to head with with the 1 milligram. So in type 2 diabetes, they've done a head-to-head where they compared 1 milligram of semaglutide, which is the top dose of Ozempic, versus tirzepatide at 5, 10, 15 milligrams. And at the top dose, you because they're both are licensed for type 2 diabetes, you get an additional 0.4% or 5 millimoles in terms of HbA1c reduction. But that's not to be sniffed at. That can help people get to target. And then the weight reduction, particularly at the higher dose, is probably double that, what we see with at least the 1 milligram of Ozempic, which admittedly isn't as high a dose as we're seeing with semaglutide when it's being used primarily for weight loss. But that's in a type 2 diabetes population where they're getting between 15 and 20% weight loss, so which is really tough to achieve. So you could say it's the most efficacious glucose lowering treatment other than a basal bolus insulin regime, and it's in terms of weight, only bariatric surgery is it can surpass it. No pun intended. That's what the name of the trial program is.
I was just going to say, Amar, where do you see this being used though? Because I think that is something worth considering in terms of the treatment ladder.
Yeah. So first thing I want to say is that I don't think you can compare dual incretins to single incretins, even if it's high dose semaglutide. I think a GLP-GIP or a GLP amylin or GLP glucagon are different molecule classes effectively to GLP alone. There's something in this additional class that either unlocks GLP or is a better molecule or has separate effects, something or a combination of all those things. So I think, yes, it's a good study, and I agree that, the best study that we have at the moment comparing these molecules. But I would expect a dual incretin to have better effect than a single incretin. Even SEMA 2.4 potentially, I would see a dual incretin and to have better benefits over that, and decently so. So that's just one thing just to bear in mind for myself as a clinician, just to say I think that, but still good data. I mean, I can't argue with the data that you just mentioned. Where to be used? There's two arguments, isn't there? There's kind of arguments of when you see failure of traditional GLP-1 to then go to the strength. That's the traditional method of nice and everything, treat to fail, wait for something to fail, and then can move to the next one. I think that's slightly changed somewhat though with the kind of with a lot of recommendations, a lot of people work. It's actually utilizing it earlier on. I think would be the most benefit because the most impact on where you can treat someone earlier on in the disease pathway, reduce the years spent with that comorbidity effectively, or that the time with obesity or time with H1C over a certain target, though that becomes more valid and it has impact on the complications down the line. So I'd really be using it earlier on, certainly. If weight loss is what is the key thing, one of the key parameters, what you're looking at and what you want to improve on, these medications need to be used a lot sooner, regardless of the condition that currently they have. Obviously, safety-wise, it's actually looking at that from the patient perspective and what they want. But that's really where it's seen. And if you look at the licenses for certainly tirzepatide, what the MHRA have said, bear in mind it's not a nice tag, we're just waiting for that still, in obesity. It's quite broad, actually. It's BMI over 30 and BMI less than 30 as well, 27 plus, and any comorbidities, basically, which is a large proportion of anyone with a BMI, effectively. So it opens up to a large number of people, which means if you're doing that, you have to consider, well, it should be used a lot sooner. There's no point waiting for a lot of these things. So, for me, my point of view, it needs to be used a lot sooner. And we can all, we've talked before about intermittent dosing or continuous dosing. There's arguments for it needs to be lifelong, but equally we don't have any data really suggesting whether you stop it and restart or drug holidays, and we've talked about this. So again, there's a lot more that we still need to learn from the practicalities of this and the duration. But I'll certainly use it earlier. And then it's just good to be able to have options, really. Hopefully, once if we get enough supply.
And if there isn't enough supply of a GLP-1. Does it suddenly get promoted up the treatment ladder?
That's the worry. That's the concern. You kind of would have people saying, "Oh, let's just hold off. Let's just wait until we get this because it's a new approval. Maybe we can wait for it to come into supply and be able to use it for our patients." But then again, you're delaying time. Your patients are the people who have got weight or HbA1cs in certain that they're still spending time in that unsatisfactory, what you don't, the target that they don't want. They haven't got there yet. So you're delaying treatment effectively, and ethically, can you justify that if you don't know they're going to get it? I don't know if we're going to get our supplies. I don't know if it's going to be the answer. Why wouldn't you do something now to help support them and treat them, and then see what happens down the line? I don't think it should delay treatment. You should still continue to manage as best as you can in the current situation. And if new treatments and new things come along and supplies there, fine, perfect. But until then, I think from a clinical ethical point of view, I wouldn't want to wait. If there is supply, and I don't see how you would be able to get sufficient supply for everyone that would need it. I certainly would prioritize the people who have complications already and comorbidities, and certainly type 2 diabetes. I would. And then the new batch and new generations, yes, that's fine. But it's difficult and it's a tricky one. It's something that does need a bit more. I think it needs a bit more planning, is the honest answer. I don't think we can, if it just kind of said, here you go, that was going to cause a lot of inequity and imbalances and problems. So it does need a bit of careful thinking, and that's everyone's really job.
So just to wrap up, I know we've covered a lot of different things today. Something that's hot off the press, and I know that we've tweeted about this today on X, about the SELECT trial results. Who wants to just give a top line of that, really, just to wrap up things?
Yeah, more than happy to, because I was following this quite closely. And this is the SELECT trial, so semaglutide, and looking at cardiovascular outcomes with semaglutide, the 2.4 milligram dose, the higher strength dose, in those who do not have diabetes. So this is obesity or overweight, effectively. And it's the classical, randomized controlled trial, double-blinded, looking to see kind of, is semaglutide superior to placebo in sense of preventing adverse cardiovascular outcomes in people with obesity. And an interesting thing to know about this is that it looked at people who did not have diabetes, but also who had established cardiovascular disease. And the established cardiovascular disease here is essentially people who had a previous stroke, a heart attack, which formed a majority of people, I think about 3/4 of people who had a previous heart attack, or symptomatic peripheral artery disease, so a very specific kind of established cardiovascular disease there. And they're all over 45 years of age, so not a young population, reasonable age population, youngish to middle age, you can argue, yeah.
Young, really.
Fine. Still the me. But yeah, I'm using comparator. But yeah, so this is this group of patients, and what it showed essentially is that yes, in that 3-point MACE, cardiovascular mortality, non-fatal stroke, non-fatal MI, that combination, it did show benefit. It had a hazard ratio of 0.8, so 20% reduction relative to not being on it, and a number needed to treat of 65 or something to achieve that benefit. And I think it's really, that's the first trial with incretins in obesity, that's purely obesity, that shows cardiovascular benefit, and that does show that, as they were saying, obesity is a modifiable cardiovascular risk factor. So you can impact someone's cardiovascular risk by treating their obesity, which again adds further onus on kind of managing obesity. There are a few kind of nuances to the trial that we could talk about. Now, it didn't show cardiovascular mortality. The composite it showed, but it didn't show specific cardiovascular mortality. And the graphs are very interesting if you look at it. There's a kind of about 25, 26 months, the graphs kind of coalesce and then they kind of separate again. So they separate and then they kind of co-in and they separate again. So whether it's COVID, whether there's something else going on there, very interesting to see why. And there was a review by the trial committee at around that point, 22 or so, where they thought they agreed to carry on. And that might have been related to that. I don't know. And it's just interesting because it looked like there's separation of the curves by about 3 months or earlier on, which suggests maybe is it more than weight loss? Is there something else that the incretins do that has impact on the cardiovascular risks potentially? And then there's also some data on nephropathy as well, the secondary outcomes if you look at, which showed potentially there's also some benefit on the kidneys, which we expect from the blood pressure. There was no blood pressure data. Again, it'd be interesting to see that. Looking at the kidney data and also the heart failure data. So they did show numerical reduction in hospitalization for heart failure, which is a secondary outcome. And whether that, we know that about 20%, 23% of the population had existing heart failure, which again, from the HFpEF trial for semaglutide, we know that has benefit. So again, it'd be good to see a bit more data and granularity amongst that, which I'm sure we will. And really, yeah, again, there's a lot of kind of things we can nerd out about and talk about the specifics of. But essentially, it shows that it's beneficial and it reduces cardiovascular outcomes.
And I think an important thing to bear in mind, it was stopped early, this trial. So although, as you're absolutely right, it didn't achieve, because there was a hierarchy in terms of outcomes, and so it just fails statistically to, although there was a numerical reduction, what it didn't achieve, it was 0.07. So, and because of that, you can't say it reduces mortality because they were further down the hierarchy, but it was stopped early, and therefore that reduced the power essentially to make these sorts of assertions. So it's which is one of the frustrating things, but it was stopped early because of the safety.
But they had a pre-specified kind of 2/3 of the events had kind of achieved, so they would have some strength around that. But yeah, you'd kind of think the longer the trial goes on, you might see a bit more separation again, which might kind of strengthen that. The other thing was also it showed an all-cause mortality reduction numerically. Again, depends what. It'd be good to look at that granular to see what was the mortality, what were the differences based on what kind of mortality. The main reason for the benefits it's shown were essentially it was the non-fatal MI. There was a notable reduction in non-fatal MI. Some of the cardiovascular mortality, but non-fatal MI. And again, this is the people who had already had a heart attack before, so again, it showed an impact in this higher risk group. So it makes sense. But yeah, it's further, as you said, Amrit, we said in the very beginning of this. There's a timeline. There's a development. There's things over years from the GLP-1 twice a day to the once a day to the once a week to the use in obesity to then the molecules, and now also use in cardiovascular reduction as well, risk reduction as well. So we're slowly seeing more and more the story being kind of shaped a little bit more about that, and we know where else we can go. We look towards the other molecules as well to see whether they show cardiovascular benefit. We look towards perhaps some of the higher strength and other strength molecules to see what they show, and we look at other outcomes as well. Fatty liver you mentioned as an impact there. Will that link with cardiovascular, kidney, liver, all kind of coalesce again with these medications again?
So I have two questions, one to Patrick, one to Yama. The first one, Patrick, so does this mean that you mentioned pilot programs for referring patients to access these molecules if they're overweight or have obesity? Does that mean that if someone's had a heart attack or a stroke before, they'd be higher up the pecking order?
I'm not aware of that, to be honest, but you're absolutely right. They should be, shouldn't they? If we're going with the evidence, we should be treating those most vulnerable, those most worthy of treatments, in a sense, those with the greatest need. And the difficult thing is trying to define need is often pushed by other individuals. But my understanding, it's just the access is just as per NICE guidance, which doesn't mention cardiovascular disease, other than talking about comorbidities, which I think you could argue is the case there, but no, I don't think that's a criteria that I've seen. These pilot programs are still being shaped and formed, so that it feels like I should be perhaps sending an email to my counterpart in the Northeast Northumbria who leads the obesity rather than diabetes side of things. So yeah, that's a good thought, and I think I might do that. So, but yeah, at the moment, but yeah, we should be going with the data, and we should be trying to prioritise these, particularly in a health system where it's funded through taxation. Those people are going to get the greatest utility from an intervention.
I could come in there and be difficult and say, well, okay, these are people who are established versus the people who have potential to prevent these kind of complications and have the most impact on their health and also their health economy. But I'm not going to. I'm saying I have thought of that, but I'm not going to talk about it now.
But where's the data though?
Projected. There's projected things we see.
Okay.
Well, no, maybe not so far. I see. I mean, we've seen it with kind of like SGLT2s, for example, the projection of dialysis and dialysis and the potential years you can save and that impact on the cost. So there will be, I'm sure. I think that there is some data on obesity. Actually, there is data on obesity complications and managing obesity will reduce kind of impact. I'll need to find it, but there is. Not specifically molecules, but just generally treating obesity does impact.
My second question was going to be to you, Amar, which is, we've spoken about, and this is probably my final question, which is, we've talked about on and offs, being on, I've forgotten the phrase that we use for it, being on...
drug holidays?
Drug holidays. So being on intermittent pulse therapy for example, high-dose semaglutide. How do you think that will have an impact, potentially, on reducing cardiovascular events and mortality?
Yeah, so I guess with glycemia, we see legacy effects. In terms of cardiovascular disease, I'm not fully aware of whether there is what's it called, legacy effects. Now, the issue that we do have is the data we do have with people who have stopped these medications. There is quite rapid and significant weight regain. Mm-hmm. They may not go back to the original, but they're, as things stand, all the trials with, well, I think that's one where the trials with, with semaglutide and with tirzepatide have shown the weight regain on stopping. So it's the issues that you will get. You are increasing the risk. The moment you stop the medication, you are driving to increasing that risk again. It has other benefits in terms of blood pressure reduction and cholesterol potentially and other things. But yeah, I suspect there will still be a kind of an interim gap. I think the longer time they spend out. So what's the sweet spot? What's that duration of time you spend off the medication before you go back on it? I don't think anybody knows, and anybody's even tried to figure out. We can get some evidence, I guess, from longer-term follow-ups of the trials, but also maybe bariatric surgery again to see what happens. The dieting and looking at that side of things as well. But I think it's tricky. It's tricky to know exactly when to re-intervene, actually. Or you have I think what the cutoff is, so you lose 20% of your weight, which is great. Or 25%, as the new molecules coming, maybe. But 20-25%, if you can lose that, 15 to 25, fine. But yeah, if you lose that, at what point, when you regain 5% or regain 10%, do you then kind of have to go back on it, or is it kind of related to the original body weight, or what? And the argument is really this weight loss should really kickstart kind of other interventions, lifestyle, dietary modifications, and actually a mental maybe processing of kind of changing the way the individual maybe does things, and that's probably maybe a bit altruistic, but that's kind of the thought process. So you wouldn't need to go as much on that on the medication when you get to a stage. These are all interesting points then, and actually a good question that we don't know. And we, as I said, I think we said before, we'd like to have a trial where they look at pulse therapy, where they look at cessation and reinstating the medication, and look at that a bit more detail. And impact on cardiovascular risk factors, which they should be able to do, and then you can project. But until they do that, until we do know, whether that's an independent trial or company trial, I don't know. But until we do that, we're just left kind of asking that question, as you have, and trying to formulate some kind of clever way to kind of think about it. But yeah, honest answer, I don't know. And I don't know about legacy effects from the cardiovascular side.
Having those trials, that's the question that the two of you were debating in a random park in Amsterdam not too long ago, I think, wasn't it? Yeah.
It was.
And whether those trials will take place, for this sort of, a manipulated sort of regime, I suppose, in a way, which I don't know whether the pharmaceutical companies would be particularly interested in.
Systems, but this is for health systems to do. These are pragmatic, observational studies rather than expecting the pharmaceutical, because their job is probably slightly less altruistic. Their job is to produce the products, maximize profitability for their company, and because they'll only have a window of opportunity to make money out of this. And because remember, these drugs will become, as Amar said already, will become generic down the line. So our children might have better access to some of these therapies, but yeah, at the cutting edge, it's tougher, isn't it?
Brilliant, guys. Thank you both. I think we got there in the end, and I think it was just nice to have a conversation with the two of you around this really hot topic, one which is going to continue to evolve, and I'm sure we're going to have many more discussions about it in the coming weeks and months.
I think we went through the whole history of it almost, didn't we? It's kind of covered incretins.
yeah, definitely. But there'll be more, I'm sure there will be. Brilliant. Thanks a lot, Patrick. Thanks, Amar. Hope everyone who's still with us at the deep end of this, the very, very deep end of this episode, enjoyed that, found it useful, thought-provoking. If you're interested to hear similar, perhaps even shorter episodes of this, please do subscribe to us on our YouTube channel, follow us on X as well, and we look forward to interacting with you there. But for today, that's all from us. Thank you very much. Take care, everyone.
Thank you.